If anyone has any questions, please do feel free to pop it in the chat. I'm not able to see whilst screen sharing, so I might ask Rich, or I might check from time to time, or we'll just go through them in the end. So to start off with, I'm just on behalf of Bite Medicine, just kind of would like to just give everyone a brief overview of Bite Medicine. It's a question bank. It's really great. It has a lot of kind of comprehensive questions, very challenging SBAs to help you with the revision that you're undergoing, which I'm sure is quite stressful because I went through the same thing last year. There's also an online textbook, which is very comprehensive and which I found very helpful as well. So I was part of the MLA trial exams last year, and I did find Bite Medicine quite useful. I found the cases quite helpful as well. So I think if anyone wants a recommendation, I would personally recommend doing them as well. And do subscribe if you haven't already. Yes, so we'll make a start. So today we're going to go through, a few of the common breast conditions, such as breast cancer, and a few kind of breast lump differentials, such as breast lumps and pain, and some high yield concepts, and also some top decile stuff that people who are aiming for honors would want to go for. So I wouldn't be able to cover everything about breast surgery today, but I've just kind of picked out from my own experience, as well as Richard's help and support, kind of what the main concepts are, what's important to know. I'm not sure what level you guys are, but I've kind of set this presentation today to medical exam finals. So if you guys are taking the MLA, hopefully this will be helpful to you. Okay. The slides are a bit, yeah, so these are the conditions that we're going to cover today. Just a brief overview, and before we make a start, I'd just like to invite everyone to join the Mentimeter poll at if you guys can go on your phone or iPad or something and put go on mentimeter.com and then put this code in, you should be able to join the poll. That will allow you to engage in the SBAs kind of coming up. I'm just going to set it up right now. Present. If you guys would like to join and put the quiz. Can everyone see my screen? Or... Yeah, so sorry, it's menti.com. Let me know when you have joined. Just give a few minutes. Yep. Is everyone able to join? Or... Okay, that's fine. I'll just leave the code in the chat so people can join later if needed. Okay, that's fine. We will make a start. So we'll start with the first SBA. So the history is a 26-year-old woman presents to the GP complaining of a 2-month history of a lump in her left breast. She reports no breast pain or nipple discharge with the lump. The breast lump is smooth, mobile, and has regular edges. It's located around at the 4 o'clock position. She does not take any regular medications and has no allergies. Her father has had breast cancer at the age of 67, but no other family member has been affected. The question tonight would be, what is the most appropriate management plan? I'm going to skip to the mentee slide. For question 1, so I think it's a bit more helpful if you guys look at the mentee and look at the screen at the same time, so you can have a look at the STEM. I think the question's up. Please do put your votes in. Okay, I'm just going to skip to the next slide. Oops. So what's the most appropriate management plan for this lady, 26-year-old lady with a left breast lump? So I'll give you guys 10 more seconds to think about it. All right, so the correct answer is refer her to secondary care for triple assessment of the breast lump. Well done to whoever got it right. So because her father has had breast cancer, so that would warrant kind of a red flag. So that would trigger a referral to a 2-week wait suspected breast cancer clinic. All the other options are kind of reasonable, but they probably wouldn't be the safest options to do. The first one, reassurance, because it does sound like a fibroadenoma with the history, but because she's got family history of breast cancer, the safest thing to do would be to refer her on. COCP is not indicated. Tamoxifen is only used to treat breast cancer, and we don't know for sure if she has one. So the safest thing is probably to refer her. And that's the same for the referral for the excision of the lump. We're not sure of the diagnosis, so we wouldn't want to operate on someone whose diagnosis we're uncertain of. Right, well done. So family history, briefly, I think this family history bit is quite advanced and top decile, so I would recommend those who want to go for honours try and remember them. How to remember them is you split kind of the first part and the second part. So the first bit, it's just remember 3 kind of main features, and what single relative that's affected would trigger a referral. And that's the first feature is when someone in their family has been diagnosed when they're younger than 40, and a male relative, and also bilateral breast cancer, where the first primary was diagnosed 50 years before 50 years. Those are the 3 features which present in any single family member would trigger referral. And then the second bit would be any kind of 2 first-degree or second-degree relative that would be affected at any age, or kind of 3 first degrees or second degree relatives diagnosed with breast cancer at any age. There's the second one is with breast cancer and ovarian cancer respectively. So just remember that it's 2 relatives and first for the first part and 2 relatives for the second part, if that makes sense. Brilliant. Yeah, that's about it. And just wanted to check with you guys if you're happy with what first degree and second degree relatives mean. In case, I'm just going to explain it. So first degree is like someone you're directly related to. So your son and daughter, your mother and father, your siblings are first degree relatives. Second degree relatives are like one that's 1 generation kind of distant to you, like your uncles, aunties, granddads, grandmas, and grandchildren, if that is relevant. Brilliant. Let me check if anyone has any questions so far. No, I don't think anyone has any questions, so we'll move on to the second SBA. Yeah, so just showing you guys kind of a mammogram and how breast cancers look like. The breast cancers here, I mean, it's quite obvious with the tumor, but I mean, as a final year, I think you would be expected to pick up these things if shown a mammogram. So yeah, we will move on. History, the second question. We'll move on. So the next question is about a 32-year-old lady presenting to the GP with a 5-day history of breast pain. She's currently breastfeeding. She's also feeling feverish and tired. She has attempted hot compresses, massages for the past 2 days after consulting with a GP before, but to no effect. So on examination, she has red and tender left breasts. The question today is, which is the most appropriate management option? I'm going to start the Menti quiz. And yeah. Okay. And I'm gonna give you guys about 10 more seconds to read the stem and try and remember it. Then we will move on to the options. Okay, so we'll move on to the options. Do you guys want to prescribe a course of flucloxacillin, refer urgently to general surgery for incision and drainage, urgent 2-week wait, suspected cancer referral, or prescribe a course of gentamicin, or reassure the lady and follow her up in 2 weeks? Which would be most appropriate? Oh, so yep, so the poll has finished, and 4 out of, I believe, 8 of you have got it correct, so well done. The answer is prescribing a course of flucloxacillin. The indications for antibiotics is usually when the person is systemically unwell, you can see a nipple fissure, or if they're worsening, if they're reporting worsening symptoms, or their milk cultures have come back positive, that would be an indication for flucloxacillin. Referring to general surgery would be appropriate if she had a breast abscess, but there's currently no kind of clinical indication that she has a breast abscess. You'd see a swinging fever, and you'd also kind of see a mass if there was an abscess. Urgent 2-week wait. She's a young lady. She's got the most likely diagnosis is probably mastitis, so a 2-week wait wouldn't be the most appropriate. Prescribing course of gentamicin. Gentamycin's not an appropriate choice because it's a nasty drug to prescribe. You have to write up all sorts of charts, lots of paperwork, and it requires bloods to be taken to monitor if someone is placed on a course of gentamicin, and it doesn't cover the organisms that we want it to cover, really. Reassurance, because the patient's clearly unwell and is worsening, and the conservative measures before aren't helping, it wouldn't really be appropriate to manage the patient conservatively. So just a brief kind of overview about lactational mastitis. It's the inflammation of breast tissue, and it's most commonly caused by milk stasis. And when bacteria kind of come across that milk stasis, they can cause infection, inflammation. The commonest infective organism is Staph aureus, because it's usually present on the skin, so it can easily kind of go into the milk ducts and just cause an infection. That can be quite annoying, and that's why we use flucloxacillin, because it's a gram-positive cover. So clinical features, very straightforward, as mentioned in the case: breast pain, fever, red hot swelling, and management would be initially conservative. You would make kind of the lady continue breastfeeding, continue kind of expression of the breast milk, and hot compresses to the breast and massages, etc. And if that doesn't work, or if they're worsening, or if breast milk culture is positive, or if there's a nipple fissure, then you would initiate antibiotics, being flucloxacillin. Any questions about this question? Please let me know in the Q&A. Okay, if not, then we move on. If anyone is typing up a question or anything, just leave it till the end. I'm happy to address it afterwards. SBA question 3. She's an interesting case. 92-year-old lady has a breast lump. She has got multi-morbidity. She's hypertensive. She's got heart failure. She's got a previous MI. Examination reveals a JVP of 7 cm above the sternal angle. She's got bibasal creps, bibasal pedal edema. She's very swollen. There's a 3 cm diameter, immobile, non-tender swelling of the upper outer quadrant of her right breast. So you've done all the investigations workup. They reveal an infiltrating ductal carcinoma, which is ER positive and HER2 negative. She's then started on an aromatase inhibitor and bisphosphonate, which is the next most appropriate treatment to offer. I'm going to start the Menti quiz. It's timed as well, so... Oh, it's not timed, this one. Never mind. But yeah, take your time. I will switch to the next appropriate slide. So the question is, which is the next appropriate treatment to offer? Would you offer this 92-year-old lady chemotherapy? Would you offer her immunotherapy, breast conserving surgery, radiotherapy, or is there no further treatment needed? I'm going to give you about 1 or 2 minutes to vote. Okay, I think most of the votes have come in. 4 out of 7 of you have answered correctly, and that's really well done. The correct answer is no further treatment needed. I think there's a good kind of good going discussions with regards to the ceiling of care of certain patient groups in the wards on the NHS. I'm not sure if you guys have come across respect forms and ceilings of care and DNA CPRs. I think because this lady is 92, she's really kind of elderly and she's got a lot of kind of comorbidities that makes you really think that if we treat this cancer, is it really going to do her any benefit, kind of making her go through that surgery, making her go through chemo, making her go through radiotherapy? Would there be really any benefit then to cause her a lot of side effects and everything? All the other options are kind of potential management options for breast cancer, and they should be considered and discussed, definitely. But I think in this case, we would consider this, there would be not much good done to her if we were to really treat that cancer, if that makes sense. So I just wanted to quickly kind of run through breast cancer management. I've drawn up a few diagrams of different surgical techniques that we can use in breast cancer. And it depends on kind of a lot of patient factors and a lot of kind of other factors as well, such as their kind of hormonal status, how their performance status is, their social history, etc., etc. But here I think as a final year, it would definitely be good to be aware of the different types of surgery available. So there's wide local excision lumpectomies, which are quite kind of common for like localized cancers. There's total mastectomy, and there's modified radical mastectomies and radical mastectomies, which we take out lymph nodes as well as the whole breast. And then there's nipple sparing and skin sparing mastectomies, which are like twists on mastectomies to kind of conserve the overall appearance of the breast. So these are about the surgical techniques. And then there are other kind of management modalities to breast cancer. I'm not sure why this slide is not going. Yep, there we go. There's radiotherapy. Some of the indications would include breast conserving surgery, mastectomy, having multiple positive lymph nodes for the tumor spread, having large tumors or positive margins when you excise the tumor. There can be hormonal therapy for ER positive patients. And yeah, they're estrogen receptor positive. So usually we test for 3 receptors. That would be the estrogen receptor, the progesterone receptors, and the HER2 status, I believe. And for ER positive patients, you would start them for 5 to 10 years. If they're premenopausal, you would start them on tamoxifen, and the second line would be goserelin. If they were postmenopausal, like this lady in the case we discussed earlier, you would start them on anastrozole or letrozole, if that makes sense. And there's also biological therapy, which I just mentioned, HER2 receptor. You start them on trastuzumab, which the brand name is Herceptin, but the kind of the generic drug name that I think people would prescribe is trastuzumab, because it's a monoclonal antibody. And chemotherapy. I think this kind of chemo in breast cancer is usually reserved for triple negative patients, which are all ER negative, they're progesterone receptor negative and HER2 negative. Yeah, or really advanced disease. Does anyone have any questions before we move on? Running a bit short of time, so I might speed up a bit on the explanations. Any questions at all? No? Okay, so we'll move on to question 4. So we've got a 67-year-old female now who presents to the GP with 3-month history of a lump in the right breast with associated skin tethering. Her last screening on the mammogram was normal. She's currently on HRT and her mother was treated for breast cancer. Which of the following risk factors per se has the strongest association to development of the likely diagnosis? So I'm going to start the quiz on Menti. So there are 5 options. One is being female. Second is a BRCA mutation. The third one's previous history of breast cancer. Fourth one is smoking, and the fifth one is having an early menarche. Going to give you a few minutes to vote and answer. Okay, yeah, I think time's up. Well done to the 2 out of 5 people who got it correct. It's a BRCA mutation. I'm not sure if you guys have heard of it because I think the whole breast cancer kind of was in the news a lot, kind of in the previous years. So BRCA mutations are kind of genetic mutations that increase the risk of breast cancer. Whilst other risk factors are definitely risk factors, but they're not as strong as a family history or having a BRCA mutation. And that's why in some kind of circumstances, you would offer patients with a family history of breast cancer genetic testing to test for this certain mutation. So there's a lot of kind of risk factors for breast cancers. Increasing age, being female, previous history, family history, having proliferative lesions in the breast, alcohol, smoking, and some genetic syndromes as well. The BRCA mutations I've mentioned, and some weird and wonderful syndromes, Lee-Fraumeni, Klinefelter, Peutz, Jeghers syndrome. And I think for high yield content, the main point to remember is definitely the fact that breast cancer is hormonal, very much hormonal in nature. So one of the biggest risk factors and the principles to remember is estrogen exposure. The more estrogen you're exposed to as an individual, generally the higher risk you are for breast cancer. Yeah, so they can be endogenous, they can be exogenous for the estrogen exposure. Endogenous, obesity, early menarche, late menopause, late pregnancy, or nulliparity, you would get kind of more estrogen exposure because of the menstrual cycle. Obesity, because I think estrogen is kind of converted into the lipids, kind of a lipid cycle. Exogenous sources, being on HRT, OCP use as well. Okay, any questions at all about this, the risk factors? If not, then I will move on. So the next question is about an obese 19-year-old woman who was referred to the breast clinic with a breast lump, which has been present for 2 months. She describes kind of how it's distorted the shape of her breast. She also states that, interestingly, approximately a year ago, she was involved in a road traffic accident and had injured her chest wall, but then confirms kind of all her injuries was healed. So when you examine her, there's a firm irregular mass in the upper outer quadrant of her right breast. There's some associated skin tethering at the site of the lesion. You've examined her axilla as well for completion, and you couldn't find anything in particular. You have attempted to take a core biopsy with ultrasound guidance. Which of the following options is the biopsy most likely to show? I'm going to start the Menti quiz. Oh. And the options are necrosed adipose cells, duct-like structures, marked stromal lymphoid infiltrate, apocrine metaplasia, and intraductal proliferation of epithelial cells. Give you guys a few more minutes to put those votes in and think about and test yourselves as well. It's important. I think it'll be useful if you guys really engage yourselves in answering these SBAs. Brilliant. So all of you have gotten it correct, 100%. Well done, guys. So yes, it would be necrosed adipose cells. So this patient with the history, because there's a history of trauma and that breast lump, this patient has fat necrosis of the breast. Yeah, I just put a note saying that breast cancer at 19 would be very unlikely, but it's not impossible. But it would be kind of the lower on our differential list, really. I'll just quickly go through the other options. Duct-like structures is a fibroadenoma. Duct-like structures lined by lower columnar cells and then separated by loose fibrous tissue is fibroadenoma. You would get a mobile lump, the breast mice, they call it. Marked stromal lymphoid infiltrate would be consistent with medullary carcinoma of the breast, which is less likely in this patient. Apocrine metaplasia, it's commonly associated with fibrocystic breast disease. You get kind of that periodic breast pain and having multiple cysts in each breast. Last but not least, intraductal proliferation of epithelial cells. That would be in ductal carcinoma in situ, DCIS in breast cancer. So again, it's less likely. Just a quick overview of fat necrosis of the breast. I won't kind of go into too much detail because I think all of you are quite confident. It's just kind of a non-suppurative, it won't cause pus, kind of inflammatory process involving kind of the fat tissue in the breast. And because it's often as a result of trauma, which causes hemorrhage and saponification of the fat tissue in the breast. It can kind of clinically, it can mimic breast cancer, but I guess you have to take into the other kind of factors of the patient. We've discussed kind of the risk factors for the patient for breast cancers earlier. So when you approach kind of these types of patients, it will be good to be aware and elicit those risk factors in history taking when you ever come across a patient like this. Anyways, managing this patient, you have to communicate with them that this is a benign lump, because they would be scared and they would panic usually. And I think getting to that conclusion of fat necrosis involves ruling out breast cancer because of clinically how similar they are. So patients would usually kind of go through that triple assessment and the biopsy and everything, and is usually managed conservatively. Any questions at all about this fat necrosis and this question? If not, then I will move on. Right, so we moved into the top decile question of this webinar. So it's for those who want to challenge it themselves as well. So this case history is a 55-year-old woman who presented with a 2-month history of breast pain. She reports over the past 2 months, the left breast had become more red and itchy and hot. She'd also noted some redness and swelling of the nipple a year prior. On examination, the left breast appeared generally red and tender with nipple inversion, but kind of localized to the breast. She presented to the GP 3 weeks ago, having completed a course of flucloxacillin, and she has said it's not done anything to it. So which is the most likely diagnosis? I'm going to start the Menti quiz. So have a think in the meantime. Right, so is it Paget's disease of the nipple? Physiological changes due to aging? Is it cellulitis? Or is it mastitis? Or do you think it's inflammatory breast cancer? A few minutes to get people voting and thinking. This is a challenging question, so I think if you have a think, give it a go anyways. It's better to get it wrong here than in your exams. So about 40% of people got it correct, which is really well done. Yeah, the correct answer is inflammatory breast cancer. So this is a bit of a tricky question. Because of her clinical presentation, she's got a history of inflammation and she's had antibiotics, which has done nothing to her symptoms. So you're thinking there's inflammation, but what else can cause inflammation besides from an infection? That could be malignancy, right? I think a few of other people chose Paget's disease of the nipple. I would agree that she, I guess, has features of Paget's disease because her nipples are like affected, but that wouldn't kind of explain everything going on, and it's a diagnosis. So I would say inflammatory breast cancer would probably be the best kind of word to put on this lady. There was one other person that said, sorry, there was one other person that said mastitis. Whilst it is something we would think about in the beginning, I think what was worrying was that she was using antibiotics, but that didn't do a thing. It didn't kind of resolve it at all. And it was still there for a few months. So I think mastitis was a possible differential, but we'd be thinking about something more sinister in this case. It is a challenging question. And I think in these cases, you'd be referring to a senior anyway. But yeah, I saw a case on the AMU personally. There was a lady with extensive cellulitis, but that kind of cellulitis spread across her breast and down in her abdomen as well. So that wasn't really suggestive of breast cancer. Breast cancer is more localized and it's red. Yeah, it was because that lady also had a kind of history of breast cancer, but because her lymph nodes were removed, so that kind of compromised her lymphoid drainage and therefore her immune system. So I think that's why she got that extensive cellulitis. She was better on IV antibiotics. So yeah, something to think about. Anyways, some of the clinical features of breast cancer. Very straightforward. I hope you guys can really drill this in your mind because this is high yield. Painless lump, skin changes, nipple changes, the peau d'orange. I can never say it right, but yeah. And some of the other signs are palpable mass. It feels irregular. It feels really firm. It feels really poorly defined. And it might be fixed towards the abdominal wall as well. And yeah, some of the worrying evidence that the tumor has gone elsewhere, metastases, is you can feel lymphadenopathy in the axilla, bone pain, bone symptoms, and kind of liver deranged LFTs and stuff, and make you think, oh, has this tumor metastasized? So that's about it for all the SBAs. But please don't go yet. We've got a special kind of rapid fire round for people, and this is to really check your reflexes. So we've got a couple questions lined up. I would like you guys to approach this in a very reflex manner. So if you guys think, oh, it's this, then put this answer. Don't really hesitate. I think the point of these questions is to really engage yourself in active recall and train up that doctor sense and the instinct in you so you can pick up red flags. So does anyone have any questions from before, by the way? Let me just check. If there are no questions, then we can move on to the next round. So what's the most likely diagnosis? With the next case, have a think about what's the most likely diagnosis. So it's a breast lump. 45-year-old lady presents with 3-month history of a unilateral breast lump. She reports nipple discharge, mostly clear, but occasionally blood-stained. She reports that the lump has not grown in size over the past few months. No weight loss, no family history of breast cancer. You've examined her and you can feel a small breast lump central and posterior to the left of the nipple, the left nipple. So what's the most likely diagnosis? I've just started the Menti poll. This is a typing question. Even if you don't know, have a go, or you're not sure, still have a go. I think testing yourself would be really kind of helpful, and getting feedback on it would also kind of help you learn as well. So I would definitely encourage all of you to give it a go. Everyone has voted. Brilliant. So the answer is intraductal papilloma. So brief overview, a papilloma signifies that it's a benign tumor within the breast ducts. It's caused by abnormal proliferation. Clinical features are unilateral breast lump. It's a classic history that I put in the case. And you get nipple discharge, blood stain or clear, uncommonly get pain, affects kind of 35 to 55 years of age. You would investigate it by kind of triple assessment again, really. There's also a small risk of it turning malignant, so usually you would excise it and remove the duct. I think just being cautious, there's one thing that I'd like to go through is kind of these two, introductal papillomas and mammary duct ectasias. I personally used to get them all confused, so I just would like to bring it out, kind of the differences, and highlight kind of how different it is. Mammary duct ectasia is a chronic inflammation and dilatation of the subareolar ducts due to stasis of secretion rather than a benign tumor, which is the introductal papilloma. Mammary duct ectasias are common in postmenopausal women. It's usually a unilateral breast lump, usually around kind of the nipples as well, but you can get green or brown nipple discharge. It's common in smokers as well. So I think just recognizing that pattern between ectasias and introductal papillomas is important. Yeah, and the management is conservative, warm compressors, and wearing a support bra. Is there any questions? So someone's put in the chat, wouldn't it be difficult to exclude breast cancer with a clinical history? Sorry, did you mean the case? I'm assuming that you meant the case because you sent it a minute ago. Yeah. Yeah, it would clinically be difficult to differentiate the two of them. I agree with you. And that's why usually these patients get sent for a triple assessment anyway to rule out any kind of worrying causes. But I guess you're expected to kind of know that this is a benign diagnosis. An introductory papilloma is a benign diagnosis. But yes, I would agree with you. It's difficult to rule out if it is a breast cancer. It's unlikely though, given the history, because there's no progressive changes, there's no weight loss, and there's no family history of breast cancer. And because we discussed the risk factors as well, it'll be less likely, but I think in reality, you probably send her for a triple assessment anyway. I hope that answers your question. Yeah. There's no other questions. We are going to move on to the next last two questions, which is to refer or not to refer. So these two questions give you a case of a patient, and I'd like you guys to think about, if you are the GP or you are the student at the GP, would you refer these patients for a 2-week rate suspected cancer referral? Let's have a look at the first one. So 60-year-old woman attends the GP for a yearly review. Aside from back pain, she's fit and well and not on any medications. Her recent blood tests were unremarkable. The GP notes that her last screening mammogram last week was reported as normal. Would you refer this patient for a suspected breast cancer? I'm going to start the Menti quiz. Going to give you guys about 20 more seconds. Answer as soon as you can. Yep, that's done. I think majority of you got it correct, about 60%, 70% got it correct. The answer is you would not refer this patient because she's got back pain, and a lot of people get back pain. Me and you get back pain because of mechanical reasons, sitting up at the desk for too long, you get back pain. It can be explained by various more common reasons other than breast cancer. I mean, obviously, having a breast cancer that's metastasized to the bone is a possibility, but how likely would it be given the context, and that her screening mammogram done last week was reported as normal? So in this case, I wouldn't refer. Any questions? Okay, I'll assume that there's no questions and move on. Right, so the next case, the final case, is a 33-year-old lady presenting with a 3-month history of unilateral breast lump. She reports that the lump has not grown in size over the past few months, and she also reports no weight loss, no family history of breast cancer. On examination, a small breast lump on the upper outer quadrant of the left breast can be felt. Would you refer this lady for a triple assessment or not? I'm going to start the Menti poll. Need 20 more seconds. Okay, so we've got a very nice mix of yes and no's in the poll. And the answer is yes, you would refer her. So she's got, even though personally, clinically, I think you guys are thinking maybe it's less likely she has breast cancer, but she is a 33-year-old lady. And you cannot kind of reliably rule out that she doesn't have a breast cancer. And she's got a lump as well. So it's unexplained. And it's on the upper outer quadrant. So there are a few kind of worrying clinical features. So I guess the best thing to do would be to refer. That brings me on to my next slide, is the referral criteria to the breast clinic, which I hope you guys remember this. This is extremely high. You'll definitely remember this for exams. So according to NICE, the guidelines, a 2-week referral for a breast clinic should be made if they're age 30 and over and have an unexplained breast lump with or without pain, or 50 or over and have kind of unilateral nipple symptoms such as discharge, retraction, and other changes of concern. These points, definitely remember that, especially the age cutoff, I guess. And the other 2 points are considering a referral, such as the skin changes that suggest breast cancer, or age 30 with an unexplained lump in the axilla. Or you can make a non-urgent referral, age 30, if they're age 30 and have an unexplained breast lump with or without pain. Yeah, I think the first kind of paragraph should definitely be drilled inside your minds for exams. That's really important. But just to recap a bit about the family history that we talked about earlier, again, the 2 parts, part 1 and part 2, the first 3 are part 1, the last 3 are part 2. So for part 1, just remember, if they're younger than age 40 and had a breast cancer in a female relative, if they're male, or they had bilateral breast cancer, the first primary at younger than 50, or if they have 2 relatives or 3 relatives diagnosed with breast cancer and ovarian cancer, mix and match, then that would probably trigger kind of some red flags and alarms in your head to make you think, oh, they've got a significant family history, you should refer them to the breast clinic. Anyways, more detailed notes are available on the BiteMed website. So I definitely recommend you guys to have a look, just to brush up on these referral criteria, which I think is quite important. So that brings me on to my final slide. But I just wanted to check if anyone has any questions so far before we conclude about kind of the things we've discussed today. No? Okay. So this summary is a golden kind of sheet that I made, listing out all the topics that are really high yield. So for high yield stuff, definitely remember the clinical features of referral criteria for breast cancers, the principles of management. You don't need to know the details because that would be left, I guess, to the oncologists and the surgeons as well. Wouldn't be expected of a student. And as we talked about, not treating the patient and keeping them comfortable is an option as well for palliative management. And also breast lump differentials. Don't forget, kind of learn the differentials, learn the names, and learn how clinically you would be able to differentiate these things from another. Is high yield. If you want to go for top decile honors, learn about the different types of breast cancers, the histology of breast lumps that we've talked about, management, detailed management of breast cancers. But yeah, that's about it. Thank you very much for attending. Before you guys go, could you please, fill in the feedback link that Rich has very kindly sent into the chat. It'll take 2 minutes and it'll really help us to improve future sessions. I think we've got a question as well. What's the difference between inflammatory breast cancer and Paget's disease of the nipple? I think inflammatory breast cancer is more of a histological diagnosis, whereas Paget's disease of the nipple is a bit more clinical because Paget's disease of the nipple refers to that peau d'orange appearance of the nipple, and inflammatory breast cancer is it's a confirmed malignancy and there are features suggestive of that, if that makes sense. Hope that answers your question. But thank you very much for those attending. Before you guys all go, please don't look out for the next session in lower GI surgery happening in 2 weeks. Next Wednesday, the 27th, same time. I hope to see you guys again. And here are my contact details and the QR code for the feedback form. If you guys want to approach me about anything about SFP, kind of final year advice or studying tips, feel free to email me or Instagram me. However, and stay up to date on the Bite Medicine website and subscribe. Thank you very much for coming. I hope you guys have a great night.